Hello and welcome to Robotic Surgeon Insights. I'm joined today by Ben Challacombe, consultant urologist and clinical lead for robotics at Guy's and St Thomas's NHS Trust. Guy's has the largest robotic surgery programme in the UK, performing more than 1,500 cases a year, with I think 7 now robots. Thanks for joining me today, Ben.
Yeah, no, my pleasure, Joseph. Thanks for having us along to chat about my main love and passion, robotic surgery.
Absolutely. Could you start by giving me a background to yourself and also the robotic surgery programme at the Trust?
Yeah, I've been a consultant here for almost 15 years now. I did some of my training here with Professor Dasgupta when we were sort of in the very early stages of getting hold of a robot and doing our first trials. And since then, we've, I suppose, diversified internally in urology in terms of the vast majority of our oncology, and quite a lot of our benign and reconstructive surgery is now done robotically. And obviously in the last few years, we've expanded across to 6 different specialties on our 2 sites that are doing robotics. And we've also expanded in terms of the number of robots from initially 1 Da Vinci standard system to then an SI to an XI, and now we have 3 XIs and 2 Xs and 2 Medtronic Hugos and 1 CMR Versius. So we have 8 robots across the trust.
And you became the first trust in the UK to adopt Hugo from Medtronic last year. How have your experiences been with the robot?
Yeah, no, very positive. I suppose our mantra has been to be the forefront of new technology, to be slightly robot agnostic, and to be looking for the best robot to do the best type of surgery in different areas. And although we're the biggest centre for Da Vinci, and the vast majority of our cases are done with that, we also wanted to have a look at some of the other robots and see if they could fulfil a role. And the Hugo's been working really well. So there's 3 surgeons have been using it. I've been doing a lot of prostate work with it and some kidney work. The team are very slick at it now, and and the outcomes when we've done comparative studies to the Da Vinci cases, we found no difference in terms of operative times, in terms of oncology, ability to cure cancer, and side effects and complications. It's been very positive.
Guy's is in a unique position when it comes to soft tissue robotics, in the sense that you have the Da Vinci from Intuitive, you have Versius from CMR, and now you have 2 Hugo systems. How has the trust had to adapt and evolve as you've been bringing on these new systems?
Well, I think one of the key areas has been looking at the governance, because as this gets more complex, we've got now over 20 surgeons who are doing some sort of robotic procedure. We have also looking at a variety of different kinds of procedure, and people wanting to start new techniques. And so Hani Abdullah, one of our senior anaesthetists, now runs our governance program, which I sit on as well, and we closely inspect with robotic interested people and some people who know lots about governance but aren't into robotics, aren't biased in any way, aren't sort of enthusiasts particularly, to make sure that we don't go too fast or go to anything that is too dangerous. And so, for instance, with the Medtronic, we've had a very structured approach to bringing it on, doing 10 prostates and then 10 kidneys of standard nature, and then going on to more complex work. And the same has been true with the CMR, and the same has been true with looking at some of our really complex surgery that people want to start in their areas, and just seeing whether we've got the right proctors, we've done the right case numbers, it's the right people who are going to take those things on. So it's been a good challenge, and so far, touch wood, it's predominantly run very, very safely.
And last year, Guy's partnered with Proximi to launch the Robotic Surgery Observership Programme. Could you talk to me a bit more about this partnership?
Yeah, Proximi is obviously a a company which has been a startup within King's College London, and as such is within our group. And we use Proximy for all different types of education. For those who don't know, it's a sort of tele-mentoring, telepresence kind of system, really just like a slightly augmented type of a Teams call, but you have the ability to draw on the screen, to annotate. It can be used off phones and iPads and computers and in the theatres. And this enables us then to offer a sort of proctorship within different specialties where surgeons could visit, see a few cases, and then they could go back, observe cases from afar, or do that the other way around. And then once they start, they could also be mentored by our own in-house surgeons. So thoracics have had that up and running, and urology are following them likewise. And obviously our other more mature programs such as ENT are looking at whether there are people around the country and in other countries who want to link in. I mean, it seems that it's a very natural thing now. I suppose COVID has taught us that this watching people do things on calls is very easy, and it's we've been using the Proximy for this wide range of things, as well as recording all of our videos as well, and using it as a sort of a database storage system.
You chair the Trust's Robotics Steering Committee, and as early adopters, could you talk to me a bit about a typical process from becoming aware of a system through to adoption, and who some of the main stakeholders are?
Yes, well, it's robotics as a word. Of course, we've started off with body cavity robots, abdominal cavity robots. We're now into robots that do thoracics, ENT, and then we've got micro robots, we've got orthopedic robots, we've got potential other nuances on the whole robotic scope. So usually what happens is it requires an enthusiast from their area to say there is a robot, we're interested. We are early adopters. If you look at how that works on the sort of scale of technology, we tend not to be pioneers, as in we're not the people who are trialing it for the very first time, but as soon as it looks like there's some data, even very preliminary data supporting a system, we would be interested in having a look at it. I think within the NHS, we need to see that something is safe and it's been used and it's been trialed. So we tend to be the earlier of the early adopters. We present it to the board in terms of what is this robot, what's the data, have we been to see it. Within that board are people from City, who are our commercial organisation that is chaired by our deputy CEO, Nadine Haram, who runs Proximy, and some other corporate stakeholders in that. We also obviously have people within the governance group who are there, who might say, well, look, hang on, we need to have a look at that. We have people within the finance there, the people who are going to write the grants, and then and obviously the clinicians and the managers. I mean, they're all on that call as well. So if orthopedics are buying a robot, the orthopedic manager needs to have sight of that. We can't just be landing it in the orthopedic theatres without them knowing. So it's all of those people, from clinicians to managers to the City corporate group to the finance group and the admin team. And some things are presented and don't happen because they're not ready, or they're too expensive, basically, or they haven't really got you can't have a robot come in that's only going to do one case every 2 months. It's not viable. So to start with, it needs to be high enough volume that it's going to work. But we've, if you look back, actually all of the CMR, the Medtronic, they were all presented within that governance system. And then often we'll take that out of that committee, we'll form a group. Like all these things, again, learnt through COVID probably, you've got to form a Teams call and you've got to get everyone involved, and we've got to really look at it. But luckily, having had some successes, we do have a managerial support in Alice Jenner, who's our chief robotic manager, that she's very good at drawing up the grants that are required, the business cases, because it's all about getting through enough of the trust sort of committees to get approval. And we've had some wins and we've turned some things down, and there's about 3 or 4 things in the pipeline. And as you and your readers will know, I mean, the orthopedic micro robot area is expanding, and we're not really into that yet. So that's one of the things on our agenda.
And what are some of the new technologies and capabilities that you're most excited about at the moment?
I suppose in the greater scheme of the word robotic, we've got the aquablation system, which is a BPH, benign prostate system, which is truly a robot, as in you press go and it does the job. So that's up and running at the trust. We've done 150 cases of that through my colleague Rick Poper. So that's exciting. We are very keen on the new SP version of the Da Vinci, which is a single port, which has just had FDA approval a while back. It's just had CE marking in the UK and Europe, I think, the last few days of December. And so we're keen to try and have a look at that and see whether we can use that in the NHS. I mean, that's for those who don't know, it's like an endoscope with 4 arms that come out of it. So instead of having a left arm and a right arm in Da Vinci and Medtronic and then a fourth arm, the fourth arm is either above or below, and the camera therefore is either above or below. So they're like on a little sort of pendulum wheel, and you can imagine that robot is extremely attractive to ENT tours, that transthoracic. It can do work transrectally as well. It's very attractive to gynae operations. It's very attractive to urology kidney operations. So we think that there's potential there if we can do that deal, that would be have real benefits to our patients, because obviously where we're starting from is, can we do minimally invasive surgery to the best possible quality with robotics to actually help our patients? That's the end game, and that looks like an exciting system, and we've read some good reports on that.
In addition to some of the new technologies you've just covered, how else do you see Guy's robotic surgery program expanding in 2024?
Yeah, well, there's the thing that is my main driver, my passion for this at the moment is our Centre of Excellence strategy has got 3 strands, and we're never going to be arrogant enough to say we've got anyone absolutely right, but we've got the clinical thing going with all the different robots, and they're all doing things. And we've got the research side, which Professor Orsolin, Professor Dasgupta run within King's, KCL and King's Health Partners, our sort of overarching academic group. But the third strand is training, surgical training, for young trainees, trainee surgeons, for consultants, for nurses, for senior care practitioners. Our dream has always been a training centre, and we are in the process of setting that up. And that is, I think, what's going to bring us together as a group of robotic enthusiasts, surgeons and nurses. We're starting with a course in a month called Robo Start, which is an Australian name, which is basically to get really young surgeons into robotics at their sort of first year or 2 of doing surgery, before they've decided to do colorectal or urology or ENT or even general surgery versus gynae, and give them exposure, because everything in this country is geared towards higher level surgical trainees, fellowship and consultants. But actually, to get people good at this, enthused, passionate, and really take it off as a career, we need to get them in at that earlier level. So we're working with something called IMRA, which is the International Medical Robotics Academy, which is an Australian startup sort of training group that is led by Professor Costello there, who I did my fellowship with. And they're coming over, and I've been pushing it out a little bit on social media. We're going to sort of have a train the trainers course, and then a Robo Start course for the youngsters, and then I'm going to run a specialty course in my area, which is partial nephrectomy. So 3 courses in 3 days. And the idea is that we'll get a real training centre sort of up and running with all 3 different types of robots or more in the future in there, so that people can come and we have an actual establishment. They can do simulation, they can do dry labs. And why this works is because instead of having the traditional model where you have to practice on pigs, porcine models or cadavers, which is dead people, you can they have got biodegradable 3D printed, really high quality, high fidelity models for everything: prostates, kidneys, bladders, hysterectomy, colorectal. So trainees can come in and do this on a robot that the next day can operate on a patient. So it's changing how you do training, and we're really grateful for their support yeah, you can tell that's my enthusiasm at the moment, is getting that up and running with all of our different teams, and running a whole load of courses to hopefully get some education going as well.
Thanks again for your time today, Ben. I'll be sure to keep a lookout for announcements throughout the year.
My pleasure.